Okay, so hi everyone. I'm Dr. Robert McKenna, and I am a senior public health advisor with HRSA, the Health Resources and Services Administration. And it's my honor to moderate this next panel, Navigating Telehealth and the Prescribing of Controlled Substances. Please raise your hand if you have a HRSA grant or are a subcontractor on a HRSA grant. Okay, a number of you, not most people. Okay, good. So whether you have a grant or not, you may know that HRSA is the primary federal agency responsible for working to increase access to health care for vulnerable populations. And we have the privilege of doing that by administering over 90 programs to that end, with last year's budget for that being almost $11 billion. The largest program, which many of you likely know, or maybe some of you are even from, is the Health Center program, where approximately 1 out of 12 people in the United States receive primary care services. And they do that at one of over 11,000 health center service sites throughout the country. And that's just one program of, again, over 90. Others include the Maternal and Child Health State Block Grant Program, the Ryan White HIV/AIDS program, the 340B drug pricing program, and of course, many rural health services programs, including the Telehealth Network grants and the Telehealth Resource Centers. Last year, HRSA's Federal Office of Rural Health Policy awarded almost $150 million for rural health services, a significant amount of which was for telehealth or telehealth support. And if you've taken a look at the most recent federal budget, you've surely heard about it on the news, it's safe to anticipate that number is about to get a whole lot bigger, especially for programming that addresses our country's opioid epidemic, which of course is directly related to this panel's topic. So I'm thrilled to see all of you that are here and interested in that topic. Know that myself and my HRSA colleague, Natasha Manzanero, who was introduced earlier. Natasha, are you in the room yet? Okay, she will be shortly. We're really looking forward to hearing your thoughts and comments and concerns, and of course those of our subject matter experts on today's panel, so that we can help inform HRSA's and HHS's program and programming moving forward. So we thank you for that in advance. And without further ado, let's move forward. About the format of today's panel, we do have some, I think, fairly short presentations, but we anticipate this session being a lot of exchange and conversation. So please do make use of the mics in the room and of the mobile app to write comments and questions, and we'll get to them as we can. First, we'll do our presentations, and then we'll do Q&A. And let's meet our panelists. Please do read their bios in the Summit program. They're clearly impressive, and we're really lucky to have them here with us today and sharing their expertise. And those folks would be Jeffrey Boyce, Insight Telepsychiatry's Executive Director, James Arnold, my federal colleague and chief in the Drug Enforcement Administration, and Dr. Darshan Kulkarni, Synchrogenics' Vice President of Regulatory Strategy and Policy. And I challenge any of you to say that 3 times really fast. And I believe Jeffrey is going to talk with us first.
So good afternoon. Hello, hello, hello. I was nominated by my colleagues here to go first and do a little bit to frame up the issue about what we're going to be talking about. I think largely we're going to be talking about an act called the Ryan Hate Act, which exists at a federal level and has some challenges around the prescribing of controlled substances specific to telemedicine. I believe that the perspective I am hopeful to convey to you guys is the perspective of a provider organization in all of this. Got some colleagues that are going to speak about it from both a legal and a pharmacist perspective, and then also from obviously a federal policy perspective. So I'll try to start off framing up the issue from the view of the provider community that is working within this act. A little bit in terms of our breadth and the way that this impacts us. Insight is a provider organization working in about 26 different states. We are a behavioral healthcare practice that delivers psychiatry via the use of video conferencing, and we've been doing it since 1999. We find that we bump into controlled substance prescribing questions, particularly in the areas of child psychiatry, really kind of all across the board. We bump into it increasingly in the area of substance abuse treatment and the idea of medication-assisted therapy, and we also bump into it with the idea of benzodiazepines. All these are part of the psychiatry practice. So quick background on what the Ryan-Haight Act is. It's actually called the Ryan-Haight Online Pharmacy Consumer Protection Act. It was passed in 2008, and it was intended to crack down on what it deemed rogue internet pharmacies. It does a lot of things, but one of the main things that the Ryan-Haight Act does is it prohibits the prescribing of a controlled substance by means of the internet without a prior in-person medical evaluation. I think everybody would agree that the Ryan-Haight Act is a very well-intentioned and very successful law. It does exactly what it was intended to do in terms of cracking down on these rogue internet pharmacies and kind of shady online questionnaire prescribing, but it has created some limitations around the practice of telemedicine. There's 7 exemptions within the Ryan-Haight Act. I won't go through all of them, but it basically prohibits prescribing of controlled substances without a prior in-person evaluation unless one of these 7 exemptions are met. A couple of those exemptions are the patient is located within a DEA-registered facility, the patient is in the physical presence of another DEA-registered prescriber, the patient is a member of Indian Health Services, certain special circumstances, or if that prescriber has obtained special registration to practice and prescribe controlled substances by way of telemedicine. The challenge is that the special registration process has yet to be created. So the DEA, and I'm sure my colleague Mr. Arnold will tell you a lot more about this, but the DEA has published a formal agenda item to create the special registration process multiple times, and as yet, that does not yet exist. And so we all have some challenges working around or within the confines of the Ryan-Haight Act. There's a lot of activity going on around this particular issue. I wanted to frame up some of the advocacy and some of the positions that are being taken on it, and would love to answer more questions and have more dialogue after we hear from the rest of the panelists and get into some Q&A. The advocacy around this has originally kind of focused on the idea of child psychiatry and the idea of substance abuse services in particular. So with child psychiatry, hopefully folks in the room are aware that stimulants are a Schedule II controlled substance, and stimulants by many accounts are really the bedrock and the foundation of the toolkit for many child psychiatrists. There's an extreme shortage of child psychiatrists across the country. Literally every single state in the country is known to have an extreme shortage of child psychiatry. The District of Columbia is the only area that doesn't carry that designation. But with such an extreme shortage of child psychiatrists and such an increasing need for their services, we have to really look for every opportunity that we have to leverage access to those providers. Telemedicine is one of those things that enables us to leverage their specialty. Obviously, with the opioid epidemic and everything that we're dealing with, increasingly we're bumping into controlled substance prescribing questions around telemedicine in the area of substance abuse treatment, particularly around medication-assisted therapies and the use of things like methadone and buprenorphine in particular. One of the challenges of the Ryan-Haight Act itself and the way that it works is it makes no distinction between the different controlled substances that are out there. Everything is basically treated the same. There's nothing that says, well, you can do Schedule II controlled substances via telemedicine this way, but Schedule IV you have to do that way. Everything is treated the same, and as folks might know, the same problem drugs, some of the hydrocodone and opioid drugs, they're Schedule II, so are some of the solutions. The buprenorphine and the methadone in particular are also Schedule II drugs. So the problem and the solution are kind of wrapped up together from a drug standpoint and a formulary standpoint. There's been a lot of advocacy on this. A couple of my colleagues from the American Telemedicine Association Special Interest Group has been working hard to promote solutions here. The Center for Telehealth and eHealth Law has been doing similar things, and the National Council for Behavioral Health has been trying to get involved. The ATA, when that work group got together, what they tried to propose as a solution and wrote a formal letter to the DEA offering some solutions here. They really narrowed in on that idea of a special registration process for prescribers or sites to register with the DEA in order to deliver these services via telemedicine and prescribed controlled substances. That work group also suggested the option of distinguishing in some way between the classes or the types of drugs and the type of practice that was actually occurring. This was the telemental health special interest group from the ATA, and so that group really focused on the practice of psychiatry and the need to be able to prescribe certain controlled substances appropriately via telemedicine. When the National Council looked at the issue, they also focused in on that idea of a special registration process and suggested some solutions there. Their solutions were what they considered to be a belt and suspenders approach. They wanted both the site and the prescriber to register with the DEA and to obtain that special registration process. And most recently, actually last month, the Center for Telehealth and eHealth Law wrote a letter to the DEA and worked on developing some potential improvements for the Act. They focused on the idea of permitting telemedicine exam, clarifying origin sites, and creating this special registration process. Fortunately, there's also been some movement at a federal level around this issue. There are actually, I guess, 3 bills presently in front of Congress that could have an impact here. The first is the Senate HELP bill that's out there. It's really focused on the Opioid Crisis Response Act of 2018. And it's focused on creating a registration process for substance abuse facilities to be able to use telemedicine and prescribe. There are also 2 other bills out there. One is the Improving Access to Remote Behavioral Health bill. And this one is really designed around, again, substance abuse programs being able to get registered. There's also one, the Special Registration for Telemedicine Clarification Act, that would basically require the DEA to issue these special registrations. And so hopefully that frames up a little bit of the issue. I know Mr. Arnold from DEA is going to talk in much more detail about the Act itself and what is allowable out here. I'd love to answer questions when we get to that point at the end, and hopefully we'll have some really robust discussion. Thanks.
Thank you, Jeffrey. Much appreciated. My name is Jim Arnold. I'm the Chief of Policy and Liaison for the Diversion Control Division at DEA headquarters in Washington, D.C. This is not my first time speaking on this subject. It's a particular favorite of mine. And so I'm going to try to give you a perspective of the DEA and what we're here to do and what we're here not to do in regards to this particular item. And so I'm going to try to share some information that hopefully will correct some of the misinformation out there regarding telemedicine and how it can be practiced, because there is some misinformation out there regarding telemedicine. And so I'm going to try to correct the record to a degree. For the most part, telemedicine and what can be done with telemedicine is pretty much summed up really in about half of a page of information in the federal law under the definitions under 21 U.S.C. 802.54, the telemedicine. It's pretty simple and it's pretty straightforward. And I know it can be a little bit complicated, and this whole issue of one in-person medical evaluation seems to confuse the issue a lot. And so I'm going to try to correct that understanding. All right? Now, under the Ryan-Haight Act of 2008, within the confines of the United States and its territories, and I want to make sure that I stress that, a DA-registered practitioner is exempt. Now, this is what I'm going to say it again, is exempt from the requirement of an in-person medical evaluation as a prerequisite to prescribing or otherwise dispensing controlled substances by means of the internet. If the practitioner is engaged in a practice of telemedicine, it is acting in accordance with the requirements of 21 U.S.C. 802.54. It's pretty simple. It sounds complicated, but it's really not. You don't need an in-person medical evaluation if you're going to practice telemedicine. But if you're practicing telemedicine, it's pretty simple. It's very simple requirements under 21 U.S.C. 802.54, and I'm going to tell you what they are. So that's it. As Jeffrey said before me, the Ryan-Haight Act was created specifically in response to a really significant problem we were having with the internet. And with millions and millions and millions of dosage units of controlled substances being sent out to individuals across the nation who were just able to get online very simply and fill out a questionnaire and get a whole bunch of controlled substances mailed to them at their home. And that's what was going on. And the problem was as bad as that everybody, and it was as bad as everybody thinks it was. And like I said, these were rogue internet pharmacies that were going online and setting these companies up, and they would connect with somebody. In this particular case, a young man by the name of Ryan Haight, 17 years old, who was using his parents' credit card, who they thought, and his parents were medical professionals, who they thought that the young man was using the credit card to buy baseball cards. And that was not the case. And so what he was able to do was go online, fill out a questionnaire. He didn't see a doctor. He didn't see anybody else. He filled out a questionnaire, would go into the pharmacy online, electronically. The pharmacy would send it down to another hub, maybe say down in Florida, because that's where a lot of them were located. And then the hub would send the prescription up to a doctor who would be sitting in a room no bigger than about 20 by 20 with about 10 different computer terminals in the room. And what the doctor would do is go around computers and read the questionnaire only, without seeing the patient, without seeing anything, and just push the button, and out would go a controlled substance to the individual in his home. And as a result, this young man died of the controlled substances that he was receiving at his home. His mother, outraged, as well she should be, went to Congress, and so now we had the Ryan Haight Act. But at that time, the Ryan Haight Act, even at that time, Congress recognized the fact that telemedicine was already being practiced. That telemedicine was out there. So if you look specifically in Federal Register, 74 Federal Register, and if you look at page 15603, it specifically tells you what I just laid out here. That an in-person is not needed. If you're practicing telemedicine, an in-person medical evaluation is not needed. If you have an in-person medical evaluation and you're going to be prescribing controlled substances via the internet, you're good to go. Otherwise, if you don't, if you're practicing telemedicine, then it's pretty simple. And as long as you're following these requirements, remember, this is federal law. The DEA didn't create this law, but this is federal law that was passed by Congress. So for most DEA-registered practitioners in the United States, inside the United States and its territories, including qualifying practitioners and qualifying other practitioners, we're calling medication assistant practitioners. This is like a big deal right now. Treatment. Treatment is so important, and DEA fully supports treatment. And so for treatment for medication assistant providers, this is something that they could do if they follow the rules under 21 U.S.C. 802. And so if they're going to be prescribing by means of the internet, and basically what this is, the practice of medicine, the term practice of telemedicine means the practice of medicine, all right, in accordance with applicable federal and state law. As you know, federal law says certain things about telemedicine. The individual states where you're sitting in your individual state has passed their own rules and regulations regarding telemedicine. There are some states in the United States, believe it or not, that won't allow telemedicine. There are some states that you have to be sitting inside the state in order to prescribe a controlled substance. So you have to know the rules and regulations of your state. I'm just here to tell you what the federal government says about telemedicine. So it has to be a practitioner. It can't be a pharmacist at a location remote from a patient, and using a telecommunications system that is in accordance with federal law and regulations. That's probably the most important thing. There are conditions on the system that you're using. I mean, there are HIPAA concerns, there are privacy concerns, and so on and so forth. So as long as your system is in compliance with federal law regarding that, then that's one of the issues. So you have a practitioner who's sitting remote from the patient, let's say in the state of California, and he's seeing a patient. Let's start first with the state of California, within this state of California, and I'll talk about other states. So they use the appropriate system, and then if other things are done, then they can go ahead and practice telemedicine and issue a prescription for controlled substance via the internet. So there's really, for most practitioners, and that includes PAs, who, if you're a DEA-registered practitioner, nurse practitioner, a physician's assistant, a physician, if you have a DEA registration, all right, then that's what we're talking about here. So there's, for most 99.9% of all practitioners in the entire United States, the main thing here is, I'm not going to talk about the VA, I'm not going to talk about Indian Health, I'm not going to talk about emergency medical situation, I'm not going to talk about, because those are all, most practitioners practice basically under A or B. I'm going to try to make it as simple as that. So 1, A, while the patient is being treated by and physically located in a DA-registered hospital or clinic. They have to be registered and have to be a DA-registered hospital. The patient has to be sitting in a hospital, has to be sitting in a DA-registered hospital or clinic. If you're registered with DA, that's one of the conditions. Okay? The other condition is in the physical presence of a DA-registered practitioner, and I'm going to talk about that in just 1 second. But both of these two items carry with it these conditions. Obviously, the doctor has to be acting in the usual course of professional practice. All right? If you're writing a prescription for a legitimate medical need and you're acting in the usual course of professional practice, you're good to go. We're not after the good guys. I mean, we're not after the good guys, that's right. We're after the bad guys. And unfortunately, the profession has enough bad guys in it that creates a major, major portion of the problem in what we see. You guys don't see this. This is unfortunately the seedy side that we see. And we arrest doctors, we arrest nurses, practitioners, pharmacists every day, unfortunately, because they're doing bad things, they're doing illegal things when it comes to the internet. And even with telemedicine, right now as we speak, we've already run into illegal activity with telemedicine already, where there's a certain situation where you have the owner of a clinic who has a front and has basically just put a doctor or DA-registered practitioner on the rolls, just paying the doctor, but it's not seeing the patients. You're having the owner of the clinic sitting in front of the telemed and handing out prescriptions. I mean, that kind of activity is already going on. The Ryan-Haight Act was created to try to prevent that. That's why you have all these conditions and trying to control this situation. It has nothing to do with not allowing you to practice medicine. It has to do with trying to protect, and prohibit the bad guys from doing bad things with controlled substances. And that's very, very unfortunate. If everybody did the right thing and everybody obeyed the law and everybody did what they were supposed to do, we wouldn't have any law, we wouldn't have any regulations. But we all know how that works. That's why we have laws and rules and regulations, and laws in particular in reference to homicide and reference and so on and so forth, because people can't do the right thing on a regular, consistent basis. And so it's unfortunate, but that's what we have going there. So they're acting in the usual course of professional practice. So you got to be in a DA-registered hospital clinic. They're acting in the usual course of professional practice. They're acting in accordance with applicable state law. And they're registered under Section 823 in the state in which the patient is located. And I know this is a particular problem for everyone, and this is a particular issue. And it'd be nice if we could have everybody, the patients sitting at home. I would love to be sitting at home and check in with my doctor and not have to go into the office. Trust me, I would love that. But unfortunately, he makes me come in no matter what. So, but that's not, that's currently what is going on. So the reason why we have this is they're inside the confines of a DA-registered hospital clinic where there are appropriate medical professionals, where appropriate medical activity can take place. If they need an exam, or if they need this or they need that, and they're there. So there's a checks and balances on the system. So they're not sitting by themselves with nothing around, with nothing happening. So that's what, like I said, why this was created. And like I said, the other one issue, for most practitioners, like I said, it's either A or B. It's that simple. And I'm not going to get into the VA. There's some very minor exceptions for the VA, very minor exceptions, and because of their situation. And I'm not going to talk about anything else, but for 99% of all practitioners, and then some, this is the way you can conduct medicine in a legal manner and do telemedicine, even without a special registration. Although we are working on it, you can still do telemedicine regardless if there's a special registration or not. So if the patient is being treated physically in the physical presence of a DA-registered practitioner, then you're also good to go. And I'm also taking more time probably up so I better speed up here a little bit. Same conditions apply. Acting in your course of professional practice, acting in accordance with applicable state law and registered under Section 823F in the state in which the patient is located. Those are the conditions. How you can do this, and I just want to share with you because I know it's difficult, it's challenging to do this, but I also know there's very, very many business models, and I talk to people, every time I speak on this issue, I'm talking, and we get phone calls from businesses all the time asking if I'm doing this, am I doing that, would I be okay? This is how you can do it. Obviously, you have to be registered with DEA in the state where you're located. That's number one. All right? You also have to be registered with DEA in the state where the patient is located. Because not only are you practicing medicine in your own backyard, you're now practicing medicine in somebody else's backyard. You're practicing medicine, and you must follow the rules and regulations of the state in which the patient is located. So you can be in California, you can be in Arkansas, wherever, and be practicing telemedicine. You can have, patients in 10 other states if you want, but once again, you're going to have separate DEA registrations, and the conditions on the patient still exist. So that's what we have going here. So I want to go back here. So the patient is in DEA-registered hospital or clinic, that's one. The patient is in the physical presence of a DEA-registered practitioner. Once again, I'll just repeat it again. DEA-registered practitioner can be it can be a physician's assistant, it can be a nurse practitioner, it can be a physician who is registered with DEA to prescribe controlled substances. They can be in the physical presence of a DEA-registered practitioner. DEA-registered practitioner can travel to the residence of the patient, and I know it may not necessarily be, perfectly, perfect, or other physical location of the patient. I know there are some companies that have physically set up offices and have got them registered as hospital clinics to enable patients to come into that area and sit and to connect with a remote practitioner. That's one way of doing it. The practitioner can also, remember, you could hire a practitioner to travel around to all the patients' homes. You could do that. You could rent an office where the DEA-registered practitioner will be sitting with the patient. Those are all possibilities. I'm not saying it's perfect. I'm not saying it's a great situation. I'm just saying that these are some possibilities. Okay? You can rent an office and have your patients go to the office where the DEA-registered practitioner is located. I think in Missouri, there's one particular company whose model is this. They have offices, a number of different offices across the state where this is where the office and other businesses I know of have rented out offices in other states where they've done this as well. I said I'm not perfect, but I'm saying this is a possibility. A mobile van. There's no reason why, especially in rural areas, that you couldn't have a mobile van with a DEA-registered practitioner on board driving around to different towns or different locations. As long as the state says this is okay with them, there's no reason why that couldn't be done as well. So those are just some ideas. And it's already going on, as you well know. And I'm amazed at the technology. It's just incredible what's going on out there with telemedicine and what's going on. So these are just a few pictures of what's happening out there, what's going on. This is rural treatment for rural vets, our veterans, and vans that are able to travel out and reach out to them. What's trending? Total number of prescriptions being written in reference to the opioid drug problem. Total number of prescriptions being filled for hydrocodone are dropping. This is actual data. You can see. This is oxycodone, been dropping for the last 3 years. Number of prescriptions being written, coming down. Methadone. This is not the methadone we're talking about, the liquid methadone that's being given out by narcotic treatment programs. It's not what we're talking about. We're talking about methadone that's being issued out there for pain, unfortunately. Methadone is a drug that's available, but those prescriptions are coming down as well. Now, what is going up in terms of is buprenorphine. Buprenorphine prescriptions, as you can see, have significantly increased. And there are a lot of physicians out there that are writing prescriptions for patients for narcotic drug treatment or opioid drug treatment. That's getting better and better and better. These are the total number of prescriptions filled. These are all prescriptions that we track. This is data from IMS once again. This is actual prescriptions filled, As a general rule, all prescriptions that have been written for controlled substances are dropping, are coming down, especially in the pain area. That's what we're mostly talking about here. They're taking a second look and trying to do things in a different way. They're taking a different look at pain and a different look at what can be done to treat pain and to address that issue. Okay? Opioid treatment programs. You can see the numbers are going up. And as of last week for 2018, we're at 1,629 opioid treatment programs across the United States. This is your state. This is the number of opioid treatment programs in your state. As you can see, the state of Pennsylvania has 90. Virginia has 41. New York has 129. So those are actual opioid treatment programs that are out there. Now we have registered qualifying practitioners. This used to be data-way physician. This is what we were talking about in the law, the new CARA now refers to them as qualifying practitioners and qualifying other practitioners. PAs and NPs, as you know, can now write a prescription. As long as their state gives them authority, they can write a prescription in order to treat for narcotic drug abuse, opioid drug abuse. So it's coming. And there's the numbers in your individual state. Take a look at your individual state. I hope the numbers are big enough that everybody can see them in the back. Can you see them in the back there? All right, good. So those are the numbers in your individual state. As you can see, Pennsylvania has 2,594 qualifying physicians, qualifying other practitioners who are practicing in the state of Pennsylvania. So narcotic drug treatment and opioid drug treatment are getting out there. The importance of it is being pushed. Everybody's involved in this issue, and I mean everybody in the universe. From the federal, state, local levels are significantly working hard together to make sure that drug treatment is available to those who need it, even in rural areas. These are our initiatives, our outreach. We're out talking to people, sharing and talking to them. We're significantly increased. So far this year, we're up to 833 across the nation. We're reaching out, talking to people, being involved with it. We're sending out. I assume that everybody pretty much in the audience here is a DA registered practitioner. So am I correct? Raise your hands if you're a DA registered practitioner. All right. Did you get this notice in the mail, in your email regarding CDC? We sent an email out to all the DA, 1.3 million DA registered practitioners, talking about CDC's information that they have available to them. And here's the information, and here you can, to get training on prescribing opioids or to get information on for your practice, you can contact them. So we sent that out. We sent this out just 2 weeks ago. How to get help through SAMHSA. We're working hand in hand with SAMHSA to try to get information out about narcotic drug treatment, opioid drug treatment. Gave the 800 number down there. I can't fit it all on the page, but down right below that, what I couldn't catch was we give the websites where you can find an individual practitioner, a data-way practitioner who is practicing. And you can put in your zip code or your address and pull up a name. Or you can put in and find a narcotic drug treatment program. So that's what we sent out as well. So we're actively involved with them. This is something, a brainchild that I came up with in regards to putting some things together. This is a mouse pad that we're going to mass produce and send out to all and hand out to all our conferences for practitioners or whoever wants one. Talks about CDC resources. It gets information about the National Helpline for SAMHSA, and it gives information that if you contact the DEA, we have information regarding if you need information that you want to share with your patients or with or something you want to do in a local high school or something. So that information is going to be printed. So we're working on that with SAMHSA right now to push that out. We're also working on cards that we're going to hand out. Do you, a family member, need help with drugs? Gives the 800 number for SAMHSA. Call them up and try to get treatment. So we're working hard to make sure that people understand that treatment is available and that they can get treatment if they need treatment. Probably one of the biggest things that we hear from addicted individuals or so, if I only would have known about this earlier, or if I only known I could have got this information or this help earlier, it would have been a big help for me. I didn't know where to go. I didn't know what to do. So we're pushing out this information. This is the Pharmacy Diversion Awareness Conference that we just got done. We just did the pharmacies. We just finished all 50 states. We went to every of the 50 states, all the pharmacies. One-day seminar for CME credit, CE credit. to give information out from the pharmacies. We hit every state. We're now gearing up in Florida, Orlando, May 5th and 6th. We're gearing up for our first one in the state of Florida. We're going to hit the state of Florida first. Do this very same thing that we did with the pharmacies. Obviously, there's different content, there's different information, different perspective, but we're going to also do it for practitioners. We're going to start in Florida, but we're either coming to Pennsylvania or Ohio next. So stay tuned. We'll send the information out to you via the internet. We're going to notify you when we're going to have this. And I'm thinking that Hershey would be a great location for the state of Pennsylvania to have this. There's a lot of advantages to having it in Hershey. So we're still looking at venues so we're going to have that. CME credit, it's free. CME credit is available, so you can get credit for this. I know we're asking you to come out on a weekend and to get a part of your day, but I think that you'll get a lot out of the conference and the one day, and I think it will be helpful for you. So that's what we're doing. Don't forget our 15th National Take Back Day on April 28th. It's coming up. Tell your patients, tell everybody, tell your elderly folks to get the medications out of their cabinets if you're no longer using those medications and get them to a place where they can destroy it and get rid of it. Okay? Now remember, pharmacies have collection receptacles now that they can get rid of medications. Police departments now have collection receptacles so they can get rid of medication. No questions asked. No questions asked. They can get rid of these medications. So please, it's important that they get them out of their medicine cabinets because that kind of theft activity is still going on, still happening. Just a final note, and I'll be finished. I'm hoping I'm at my 30 minutes here, I hope, and not any longer. This is the one thing and the one thing only, if you can come away today with something that you want to hear from the DEA. This is my thing that I always share with every audience that I addressed. As long as you're writing a prescription for a legitimate medical purpose, and you're acting in the usual course of professional practice, you are good to go. That is the practice of medicine. DEA is not involved with the practice of medicine, not with the legitimate practice of medicine. Now, we will get involved with those individuals, and we're not going to apologize for who are engaging in illegal activity with controlled substances. It's unfortunate, but there is large-scale illegal, organized criminal activity going on when it comes to writing prescriptions. It's still going on. It amazes me. No matter how many news articles I show people, no matter how much it's publicized, and who are arresting doctors right and left, it's still going on. We have doctors in New Jersey that killed their wife because he just happened to be involved with the local, pagan motorcycle club in diverting controlled substances. I mean, you can't make this stuff up. This is real, everyday stuff, and that's part of the reason. So we have a balancing act here in terms of legitimate medical need and then trying to protect the public and provide for their safety and their protection. That's our role, is to enforce the Controlled Substances Act, because the Controlled Substances Act was written in 1970 for a reason. And so that's all we want. Everybody does the right thing, you are good to go. Please, don't be afraid, don't be worried about DEA, don't be looking over your shoulder. If you are doing the right thing and you can justify your behavior, don't worry. You don't have to worry about DEA. But if you are selling prescriptions in exchange for large sums of money and you're conducting that kind of activity, or you're handing out actual substances themselves and not a legitimate, for a legitimate medical need, then we might be coming to visit you. That's true. We will. So that's all I want to tell you. Everybody is working together. I mean everybody. States, practitioners, hospitals, treatment providers, medical schools, pharmacies. Everybody is working together to try to combat this epidemic. And it is a major epidemic. It's not a minor thing. We had over 63,000 people die this year as a result of overdose deaths involving opioids. Fentanyl is still a problem. Heroin is still a problem. Cocaine is making a comeback, unfortunately. Methamphetamine is making a comeback, unfortunately. I mean, it's still going on. But if you can picture, anybody here from Chicago? No, I guess not. You're not that close here. So picture a stadium. Picture Penn State, all right? The stadium, Beaver Stadium. That's the one I know because I grew up in Pennsylvania. 63,000. I'm sure that stadium holds, I'm not sure exactly how much they hold, but just picture that stadium. Every seat in that stadium, picture those individuals all dead. And then you'll get an idea of what the problem is and what's going on. It's going to take everybody working together. We're talking about prevention, detection. We're talking about trying to stop the problem and try to intervene with individuals when we recognize a problem. We're asking doctors to intervene with individuals when they recognize an issue or a problem with one of their patients. That's why we're sending the information out to all doctors. Education. We've got to educate people about it. It's not safe. These issues are not safe, and they're not. And we got to educate people about opioids and what's going on and what's happening. Treatment. There must be treatment. There's no doubt about that. Got to have enforcement. Got to take the bad actors off the street. And we got to get these medications out of our medicine cabinet. We have to do that. Okay. So on that note, thank you very much. Thank you.
So now's the point in the session where you all get to talk, if you so choose. I see that there have already been a number of questions put on into the app. The first question I see is, what if there is documentation from a previous doctor that documents appropriateness? What if there is documentation from a previous doctor that documents appropriateness? Remember, the topic here is, I guess it's prescribing by distance, right? So
I'll take a legal angle at it. Legally, I would say that would still be problematic because you're still the one prescribing it at that point. So I would, if I was, it's the normal practice of medicine. Nothing's changed. Even if it's another doctor, you're the one continuing the prescription. And that not only is there regulatory liability, there'd be medical malpractice issues that come into play as well. So be careful of those.
Okay.
I guess we'll all just stand up. I guess we could, instead of sitting around the corner here.
Perfect. Okay, the question that's been voted up to #1 spot. Is DEA auditing prescribers for telemedicine prescriptions?
When you say auditing prescribers for telemedicine prescriptions, we don't audit. I mean, there would be no way to do that. The way it would be done is the doctor would be issuing a prescription. It's being filled at a certain pharmacy. So if there's some reason why we would have to go to that pharmacy, and if something going on, or if we're getting a heads up from somebody, like maybe a doctor's writing prescriptions for not a legitimate medical need, and so we would go out to the individual pharmacy and look at those prescriptions. That's the only way that we could do this at this point. We could also, so that's the way we would have to do it.
I have a responsive question to that, though. Mm-hmm. There are certain states now, including Pennsylvania, that actually have a system that tracks all the opioid prescriptions written out. Right. And they're called different names in different states. Right. Does the DEA look at that and monitor that? And is there a discussion about having a centralized version of that?
You're talking about the PDMPs.
I am.
The
prescription drug
right,
monitoring
prescription monitoring programs.
Yeah.
Every state has a separate set of rules regarding that issue.
Right.
I mean, every state. That's not controlled by DEA.
Right.
And sometimes even DEA, to get access to that information, we have to get a subpoena. And so it's just not that simple. We don't have a little thing at our desk that we can just look up things. Okay. We don't have that. Really, that system is set up for doctors, physicians, practitioners, pharmacies, to make sure that their patients are not going around to 4 or 5 different doctors and getting controlled substances. Because if they are, then that's something that should raise a red flag for you in terms of something is going on here that may not be appropriate. And you may have an addict on your hands as opposed to a legitimate patient. May, but that's something. It's supposed to be a tool for practitioners. But DEA doesn't have direct access. DEA doesn't control that system. A lot of people wish that we did. A lot of people wish that there was one central system that they could access, and that would be wonderful with one set of rules, but it doesn't work that way. The states have they can make their own rules and regulations when it comes to this activity. Sorry.
Should I keep going? I have another question. This might end up being an interview, so we'll just keep going this way.
That's all right.
One of the other things I do is I'm a FDA regulatory attorney, so I end up working with pharma companies on compliance and all those issues. One of the things that they have to deal with, and they actually make sure, and they love this, is the company that used to be called IMS, and I think it's now called IQS, or I forget what it's called specifically. They have tons of data, including prescribing habits. Does an organization like the DEA actually get data from them?
We get data from IMS, and that's some of the data I showed you up here today in terms of prescriptions filled. But it doesn't get down to the nitty-gritty of the way you think it does in terms of individual patients, and it doesn't do that.
But
at least we don't have access to that information. We use it as general to see what's going on out there, see what's happening, what's going on, so we can make generalizations about what's happening. Hydrocodone coming down, number of prescriptions being filled is coming down, and that's a fact.
Right.
Oxycodone is coming down.
Right.
Buprenorphine is going up. So it gives an idea. I like to keep track of that data. Because I'm a little bit of a status guy and a statistics guy, and so I just like to because it tells me what's happening, what's going on out there.
Thank you.
Yep.
Okay, I've exhausted my questions.
Please, see somebody at the microphone. Thank you for standing.
Yes, thank you. Jim, I may have misread your slide number 5 because I thought at that point it referenced Schedule 3 through 5. So I wanted to clarify because this is a question we get asked a lot from clinical partners that the difference between controlled substance, narcotic, and a Schedule 2 stimulant. Right. Because when I saw 3 through 5, I thought, well, does this not apply to
let me fix that. I'm sorry. You're absolutely right. That was, I wanted to make a note about medication-assisted treatment. So that is specifically for medication-assisted treatment. You're absolutely right, so I'm glad you clarified that. You can do 2 through 5. It doesn't, if you're writing a prescription to treat a narcotic drug addiction, then you're only authorized certain FDA-approved items, and they would be in Schedule 3 through 5. Right now, the only medications approved for narcotic drug addiction are in Schedule 3. So that's just what the law says. So thank you for fixing that. I appreciate that very much. And no, Schedule 2s are fine as long as you're playing by the rules and under 80254, you're good to go. Once again, it's pretty simple. So.
And Mr. Arnold, while you're speaking, it looks like the top voted question is also directed to you. What is your best estimate of when DEA will publish a proposed rule on the telemedicine special registration?
Well, I really hope that, and I checked with my colleague before I came out today. I'm hoping that it will be out this year. I'm really hoping. It's a very challenging thing. We got the VA involved with it. We got, you guys involved with it. So it's a very difficult thing to, once again, to make sure that legitimate medicine is being practiced and that certain safeguards are in effect, but at the same time, not necessarily hindering or getting in the way of legitimate treatment of medicine. So it's taking us longer than we anticipated. And I wish I could give you a time frame. I can't. But I guarantee you, the minute it's published, you'll know about it. It'll be in the Federal Register. It'll be put out there, and so hopefully hopefully that'll be done. We have about 25 other major things that the DA registrants want. Remember, we just don't regulate practitioners. We manufacturers, distributors, importers, exporters, researchers. We're involved with all that kind of activity, and there's all kinds of things going on. The our regulated customers, our DA registrants, want this information. But as you know, everything was going along pretty smoothly, but now we got a new sheriff in town, a new administration, and regulation is problematic, and getting new regulation out the door is a little bit problematic. But we're meeting that challenge, and we're moving forward.
And while you're addressing that issue, perhaps a related question, would the special registration still require the prescriber to get state-by-state DEA-controlled substance registrations?
I couldn't comment on that right now. I don't know what the final thing is going to look like. Like I said, we just had Chief Counsel in the front office the other day. I was there, and we were talking about still little nuances of this and that and what can be done. The final version and what it's going to look like and what exactly is going to be allowed to be done, I don't know. But what I can tell you is, once again, you don't need the special registration to practice telemedicine. It already exists in the law. So as long as you're obeying the law under 80254, A or B, it's very simple, then you're good to go. You don't need the special registration, but the special registration is on its way.
Jim, just curious, I think in your comments you focused a lot on those two solutions, the idea of being either in the physical presence of another DEA-registered prescriber or being in a DEA-registered hospital or clinic.
Right.
Could you talk in a little more detail about each one of those? So specifically, what's involved in a facility becoming DEA-registered?
Well, it's pretty simple. I mean, but it depends upon your state. If the state will register, I mean, all hospitals have to have a DEA registration. There are surgical centers across the United States. If their states will register them as a hospital clinic or recognize them and give them a license, then they can apply to DEA as a DEA registered hospital or clinic. They can get a DEA registration. But it depends upon what the state says about the matter. Not all states would just let anybody become a hospital clinic. So it's really dependent upon what the state says about the matter.
So it's dependent on if the state defines that facility as a hospital/clinic.
Exactly right. Because I've had this kind of request and what we can do, and I gave them certain solutions. I said, here's the two possibilities. And so if they will register you as a DEA hospital clinic, then that serves one of the purposes.
And what office do you work with in the state to get the answer to that question?
Well, it would be the state board of, yeah, that's a good question. I'm not sure who in the individual state you would work. Some states like Texas have an individual office for nothing for telemedicine. You have to have a special license for telemedicine. I think it's a T number. They call it a T number. So there are certain states that, and a lot of states have rules in place already for telemedicine. But you must know the individual rules and regulations in your state. Remember, all I can tell you is what the federal government allows. I can't tell you what, I can't account for state of Illinois, state of Pennsylvania, state of Virginia, state of Florida, California. It depends upon what's going on. But a lot of people are coming up with unique and creative ways of getting this done.
So if a facility wanted to register to comply with one of your proposed solutions, how would they go about getting the answer to that question? Hey, how do I register with the DEA?
Well, once again, the first thing, it depends upon what your state says. You'll have to reach out to your state first. And if they recognize you as a hospital clinic and will give you a license to a hospital clinic or something to that effect, then you will most likely be able to apply for DEA.
So you need to be licensed by the state
You've got to be licensed by the state first. You've got to be recognized by the state. Some states won't allow certain activities to take place. It just depends. They have very specific rules on, California won't allow it. And I mean, they have very strict rules in terms of what qualifies as a hospital or a surgery center or whatever of that nature.
And I'm sorry to monopolize the conversation, but I do like your two solutions, so I wanted to drill down on them. So the other idea of being in the physical presence of a DEA registered prescriber, is that for every single encounter, or is that really just for the purpose of establishing the initial physician-patient relationship?
Technically, it involves every single encounter. That's what it involves. Mm-hmm. So you could actually hire a DEA registered practitioner. Remember, this could be a PA or a nurse practitioner, physician, whoever it could be. You could hire somebody to, you could set up an office. You could sit with them in that office. If you can't register as a hospital clinic, you could sit with them in an office. They could travel to the patient's home. I know it's not, but I'm just giving you ideas of how this might be able to get done. I'm not saying it's realistic. I'm not saying it's not difficult, or I'm not saying it's not it's cost effective. I'm not saying any of that. I'm just giving you ideas about how this possibly could be done. I mean, I'm hearing some really amazing creative ways that they are doing everything I just mentioned. Across the United States, they are involved in all those activities. It's challenging. It's a little involved, but they are doing it.
We have a patient colleague standing and waiting to make a comment or ask a question.
Oh, two. Yes, okay. I was just going to piggyback on Jeffrey's comment about exemption 1 of becoming a DEA registered licensed hospital or clinic. Groups have a lot of difficulty of doing that, and generally they can't. And these are not small groups. These are state-funded. Texas, you mentioned the MHMRs. They can't do it. Right. So is there a way to, and I mean, if the special registration, we just want a way to do this while following the letter of the law.
I know. I perfectly understand. And like I said, hopefully the special registration is going to address some of that. I'm hoping, especially in the area of psychiatry, especially in the area of medication-assisted treatment. I'm hoping that it will be able to address it. Once again, it's a balancing act, and I understand you guys are just trying to, do your thing and practice legitimate medicine. I perfectly get that, and we encourage, legitimate practice of medicine. But once again, if we didn't have the bad people doing bad things in this area, unfortunately, and they're already doing it, I mean, we wouldn't have the need for protections. It's like the U.S. government. It's like, you know, Congress and legislative branch and judicial branch. And I mean, they're there for a reason. Checks and balances on the system and making sure that things are being done on the up and up. Because nothing's to prevent a bad doctor from getting on and just issuing a prescription via the internet to a patient, you know, sitting at home for not a legitimate medical need. And so the other end, the reason the patient has to be in one of those two spots is protection to make sure that things are being done the way they're supposed to be doing. I get it. I understand perfectly what you're saying. I wish I had an answer for you, but I don't.
It looks like Darshan has a
I have
reaction.
a follow-up to the entire special registration issue. I was just curious. I understand that the final rule is not out, so that's fine. Could you talk a little bit about the challenges about creating it? What is actually causing the delay, so that we understand what are some concerns that you guys are dealing with?
Well, like I said, things are going along pretty well, but there's this whole thing about what, you know, how can we do this in such a way that protections are in place, and it's hard to explain. What can we do and how can we do it? What can we allow that is relatively safe, that is relatively protective of the situation? What can we do and what can't we do? So we're trying, it's in the weeds, it's real deep in the weeds about these kind of things. But we are looking at psychiatry, we are looking at medication assist, and I don't know what the final version is going to be. I really don't. So I understand exactly what you're saying. I understand the frustration. I understand exactly what you're saying. I can only imagine, I'm not a practitioner, but I can only imagine how difficult it must be to want to do this. And this is our future. This is our future. I mean, there's no doubt about it. When I first saw the technology 3-4 years ago, I was amazed at what is being done and how it's being done. Just incredible. I'm sorry.
We have another question or comment at the microphone.
Sure, it's a combination of both, I think. And it's similar to what other points have been raised, so I apologize if it's a little duplicative. But we are having several clients in many states that even if the state recognizes, from a licensing perspective, their entity as a clinic, they just don't fall under DEA registration. So it's not that they're having a difficulty obtaining registration or they're denied registration. They simply don't fall under their jurisdiction. They don't house controlled or any sort of substances. They don't have it flowing through. It's just they have patients who may need it. So that's why they're going through the process. Yeah. So my question is, the special registration, initially, or maybe now, is that considered a subset of your DEA registration, or is it a registration for those that I just described that just don't fall under DEA registration to start with?
It's one of the 7 exceptions under the law. I call it an exception. It's really not, I don't know if it's really, that's why I call it. It's one of the 7 exceptions that we can create the rules and for a special registration, that if it's not being done otherwise, then this is the way it could be done. So it is provided for under law, as well as the national emergency, as well as Indian health affairs, as well as those kinds of activities are currently allowed under federal law to conduct telemedicine, telehealth. Remember, this is all about writing a prescription for a controlled substance. It has nothing to do with anything else. If you're not writing a prescription for a controlled substance, which, and I understand that's what this is all about, because we're talking about Schedule 2s, a lot of Schedule 2s for psychiatry. We're talking about Schedule 3s for narcotic drug treatment. I mean, I understand that, but I mean, I wish I could share more. I don't at this point.
Okay,
Hang in there.
We have a total of 5 minutes left. I'm guessing we have room for 2 more questions. I'd like to take one at the top of the board that was voted up, and then we'll go to our colleague at the microphone. So can a medical doctor prescribe controlled medications to patients seen at home with direct-to-consumer software?
I can't address, I don't know what direct-consumer software means. Once again, all I would say in reference to that, the system has to be in compliance with federal law regarding an approved telecommunications system. Now, so that's all I can say about that. So it may not necessarily be Skype. It has to be, there's certain secure functions that have to be involved in that system. So I really can't address that, but Patients can be seen at home, but once again, the two conditions on patients, they either have to be sitting in one or two spots. They have to be in a DA-registered hospital or clinic, or they have to be in a physical presence. Right now, that's the way it stands. In a physical presence of a DA-registered practitioner. That means right here, same room. That's what that means. Physical presence of a DA-registered practitioner. It can be any DA-registered practitioner. That's all the law says.
Is there not a clarifying element to that of having a prior in-person physical examination?
If you have a prior in-person physical examination, then the law says you're good to go. Now, there are other conditions on that, but I mean, that's a different issue. I'm just trying to tell you how to practice, be able to practice telemedicine currently under federal law.
But assuming you had a prior in-person physical examination and relationship, and then you did follow-up encounters via telemedicine where you were not in the physical presence of another prescriber or a DA.
If you're doing this via telemedicine, then the rules of telemedicine kick in. Well, let me back off on that. It's a little complicated. But if you have the one in-person medical evaluation, remember this is all reference to prescribing controlled substances as a result of the internet, over the internet. EPCS would be over the internet. You're connecting with a person on the other line, and through teleconference. That's via the internet, and you're technically, assessing and making a determination whether or not you're going to issue a prescription to that individual over the system. So once again, if you're just using telemedicine and if you're just going that route, then you need to follow the rules under telemedicine. If you have one in-person medical evaluation, and a lot of that is not necessarily, once again, but all the other rules apply. You got to make sure it's been issued for a legitimate medical need, and you're acting in your course of professional practice, and you're doing the right thing. But if you have one, you have to want in-person medical evaluation in order to one, and then after that, and there's other issues. It gets a little complicated. I like to stay away from it because most people in telemedicine, don't necessarily can have the person come in because they might be in the other end of Southern California or whatever, so it's not practical.
Mm-hmm.
Okay, we have time for one final question. And those of you who have submitted questions or comments that we didn't get to, let me just remind you that the Telehealth Resource Center putting on this conference is always available for consultation. So if you have questions that you don't feel like you got answered, contact Kathy Wibberley.
Thanks. I actually have a comment and a question. I failed to see the reasoning behind being in the presence of a DEA-validated prescribing provider, why that provider wouldn't write the prescription, why it would have to be written by the telemedicine provider. It just seems like a oxymoronic rule, in my opinion. But the other one is that one of the exceptions is a declared emergency. And in the state of Maryland, our governor has declared the opioid epidemic an emergency, and President Trump has declared the opioid epidemic an emergency. Does it not therefore follow under that prescribing for opioid addiction would be an exemption?
HHS has that authority to declare a national emergency or declare a particular emergency in a certain area or whatever. HHS has that authority to do that. And I know that they have looked at it in the past. I don't know where they're at with that, but they have looked at it in the past. And the reason for, in the physical presence of a DEA-registered practitioner, once again, it's all about making sure that the situation is legitimate and that things are being done perfectly the way they need to be done. Remember how this was written, this law was the way it was originally written. You had the person on the other end that was not in the physical presence of anybody and was able just to lie and provide information that may necessarily, all I can say is this is the way the law was written. I wish I can't, because I didn't write the law. I don't really know what they were thinking, or I don't know if I could effectively explain it, to tell you the truth.
And as an HHS representative, I can tell you that's absolutely a point of discussion. There are lots of things being considered about what changes might be or what waivers may be.
I lied, I have one final comment.
Sure.
When you talk about making sure it's done right, that's what our state telehealth regulations are about. That's what the federal and state telehealth regulations cover, is making sure that we're doing the entirety of the visit in a right and correct format. So then, to me, it seems this idea of adding yet another layer of correctness in the view of DEA makes no sense at all. You don't validate whether or not I'm doing it correctly in person, so why must you validate I do it correctly via telehealth if I'm following the telehealth regulations?
I understand what you're saying. perfectly. And all I can say is every state has its own rules and regulations regarding that matter. Some are very good at it, and some are not, have very, very lax regulations regarding that matter. And I wish I could, comment further on that. And all I can tell you is when they wrote the original law and looked at it, remember, it's nationwide, applied nationwide, the same set of rules and regulations. It's not 50 different sets of rules and regulations, and one national standard. And this was the national standard produced in response to a specific problem at that time. And trust me, I was involved in a search warrant in 2 of those illegal internet pharmacies, and they were as bad as there were millions and millions and millions of dosage units going out the door with nothing more than filling out a questionnaire. That was it. And so that's why this came about. So I understand what you're saying. I get it. I wish I could argue with you, and I can't. So.
And that does bring us to the end time of our panel session. We at HHS and across the federal government recognize this is not easy, folks, and we thank you so sincerely for everything you're doing to try to help with the epidemic. And so thank you for your interest in this topic. Thank you for being here. Thank you to our subject matter experts today. Look forward to seeing you throughout the rest of the day.
Thank you.